I'm going to give you an example of sort of where we're going with funding. There's actually a case study I want to share with you. Providers actually ended up being partners in that long-term care system. Many were recruited, as I said before, because they helped the counties meet their deinstitutional goals. They basically were able to help them afford services in the community because they were on the hook for paying for them in the state institutions. So oftentimes they would save 50%. Now today, a person in southern Wisconsin Center, it costs about $600 a day. So just put that in perspective. It's always been about twice as much as it has been to serve somebody in the community, to be in an institution. So why did we get into managed care in the first place? I mean, what was the rationale for it? Well, just like every other state that's done it, and there's only 3 that have done it for this population, for people with intellectual and developmental disabilities. There's Arizona, Michigan, Vermont, and Wisconsin. I'm going to give you kind of a comparison between the 3 as a part of my presentation, but the primary reason that states do it is because they want more budget stability. Medicaid's the largest program in most states' budgets these days, and it keeps on growing by leaps and bounds. And so states had to put the brakes on, and they felt one of the ways to do that is by bringing in managed care to try to make sure that people got the right service at the right time in the right place. That's kind of Deputy Secretary of Health Services mantra. Right service, right time, right place. And the care management was supposed to assure that. States also limit their financial risk because the whole premise of managed care is that the managed care company, the organization that runs it, gets a per member per month payment, which is known as a capitation. And that capitation then is supposed to cover the services for everybody that is a member of that managed care organization. So they basically put that money out, and then the managed care organization has to make it work. So they're not seeing, hopefully, the idea is they're not seeing ever escalating costs. And the other thing is that they can hold that entity, that MCO, accountable for controlling service use and providing quality care. So those are the main reasons we went into it, and the main reason why other states are going into it. And there's probably another 10 states that are going to be going into it shortly, serving this population.